quite narrow, and we thought it's better to go for the interposition graft placement, like a loop between that remaining segment of the cephalic vein to basilic vein.
Okay. No, the loop you put in looks nice. You know, and like I said before, you got to make sure you have enough length.
So sorry for the technical issues. So Dr. Dean, my question is like, in this case, if the basilic was long enough, will it be wise to connect a basilic vein, or it's better the way we did? Dr. Dean, please unmute.
If the basilic vein would have been long enough, I probably would have geared up to do a basilic vein transposition.
In the same setting, single setting transposition, yeah?
Yeah, I probably would not have done it as a one stage,
Okay.
because let's say you do the basilic vein, you anastomose it to the brachial artery and the arm swells up huge, then the incision wouldn't heal well, and you've done a whole lot of work. Where if you do the anastomosis of the basilic vein to the artery and there are adequate collaterals and the arm doesn't swell, then you can go back in 6 weeks and transpose it.
Yeah.
But like I say, Florian's right. The textbook will tell you that you shouldn't do it if you know there's a central occlusion. But of course, I like living on the edge, and I know that it sometimes works.
Yeah. So Dr. Florian and Dr. will be updating about this case in future also. He will come in OPD in 1 week. So let's see. Can we proceed to the presentation by Sonia? So Sonia, I will be sharing the screen and kindly present about the preliminary findings. Sonia, before you present, can we have a minute so that Dr. Nobin can explain about some like the aim of this study?
Hello.
Yes, Dr. Nobin.
We have been trying to start this study some time back, because we want actually to do a bigger study regarding vascular access use, the current practice, and see how much this catheter is being used in different dialysis centers. We plan to do just a survey, a prevalence study, what type of vascular access is actually being used in different centers. So we started this program few months back, but we're delayed because of ethical approvals. Now we have started, and I think we have collected. We haven't even collected data from half of the centers. I don't know. I think Sonia can tell us what is happening.
Yes, thank you, Dr. Nobin. So Sonia, kindly present the findings.
My greetings to all. As you all know, my name is Sonia, and I am the research assistant from City Waste Unit of Dhulikhel Hospital. So today I'll be presenting the preliminary findings of our ongoing research project. We are looking at current practice of vascular access at all the hemodialysis centers of Nepal. So can we skip to direct objectives, or should we go through it?
No,
Okay.
please go through, but it may pass.
Okay, so I will just brief you about the overview of the study. In Nepal, chronic kidney disease is one of the leading cause of death, and in the past decade, the number of patients with chronic kidney disease has significantly increased. So patients requiring hemodialysis has also increased. we have total of 86 SD centers in whole country. And regarding the health professionals, only we have 56 registered nephrologists and 12 vascular surgeons. 80% of them are just practice within Kathmandu Valley. So based on few single center studies, we found that AV fistula is the most common route for dialysis access in Nepal. So, but we plan to do a nationwide study. So we conducted a study to look at the current practice of vascular access at all the hemodialysis center in Nepal. Next slide. So the objectives of this study was to assess the prevalence of the types of vascular accesses and the current practice of its creation and maintenance. We collected data using this survey form. We distributed this form to all the hemodialysis centers, and for past 2 weeks, we have collected data from about 20 centers out of 86. 65% of them are from within the valley and 35% are from outside the valley. From those data, what we found that these 20 centers have in total 165 machines that is providing service hemodialysis to total of 984 patients. That means one machine is responsible for total 6 patients in a day. Yeah. And when we look at the type of dialysis accesses, as shown by the single center studies, we also found that AV fistula is the most common type, followed by temporary catheter, and then permanent catheter, and the least was AV grafts. Now, when we look at who creates and where the dialysis accesses are created, we found that temporary catheters are mostly, all the centers have the facility to create the temporary catheters within the center. AV fistulas as well are created within the center, but pump catheters are like it is in equal ratio. Some are created within the center, whereas some are referred from other centers. AV graft is mostly referred to other centers. To create AV graft, mostly referred to other centers. And who creates is that for temporary catheters, nephrologists and anesthesiologists are the main person. For permanent catheter, vascular surgeons, and for AV fistulas, vascular surgeons are the main person, or I don't know what to say. And if in case of any issues, what we found is that nephrologist and vascular surgeon are main person who deals with the issues if the patients have any issues. So I was interested to see what is the difference within Kathmandu Valley and outside the Kathmandu Valley, and I found that there is not much significant difference regarding the use of dialysis accesses. AV fistulas are the most common route of access both inside and outside the valley. But the difference is that outside the valley, most of the dialysis access, to create most of the dialysis access, they have to be referred to the other center, mostly the city. And in case of any issues, there are no nephrologists outside Kathmandu who to handle the issues. Yeah. So I looked at the data from other countries as well, and I found that AV fistula is the most common type in other countries as well. And nephrologists and vascular surgeons, and urologists are the main uh, uh, main person involved in the dialysis access. So to summarize the findings from our data, we found that AV fistula is the frequently used access for hemodialysis. Nephrologists, vascular surgeon, and anesthesiologists are involved in dialysis access creation. In case of any issues, nephrologist and vascular surgeon are the main contact person. However, the nephrologists are lacking in at a hemodialysis center out of the Kathmandu Valley. Yeah, thank you.
Thank you, Sonia. Any would like to request for comments?
Thank you, Sonia. I'd like to add one more point. So far, the centers we have collected are from those centers that are being guided by nephrologists. Now, the centers that are left are very small centers with 2 or 3 machines that are not supervised by doctors, maybe standalone, run by nurses. So it's difficult to get contact them. They don't have any contact person, proper contact person who knows. So we're trying to call every day and get data from them. So this figures might change once we get data from all the centers.
Yeah, I think, Navin, you addressed the main problem or the main issue. Even outside Kathmandu Valley means that there's no big difference because, I mean, Dhulikhel is outside Kathmandu Valley, right? So,
Yeah.
Dhulikhel is outside Kathmandu, yes.
Yeah. So, and there's no big difference. I mean, Dhulikhel and the Dhulikhel, like Kavre district is, I think, regarding the options in terms of nephrologists as well as vascular surgeons is similar to Kathmandu Valley. So I wouldn't actually expect a big difference. And as you said, the problem is obvious to get all those little facilities from the remote areas and to see what it's like there. But there's one thing which I find interesting. I've seen so many catheters that I'm really amazed to see that the percentage is so low. But maybe it's just because those are coming actually to the hospital and those are the ones who cause the problems. So it's kind of a bias, of course.
Yeah.
Right. The way part of what I see is a huge compliment to Nepal that there's very few catheters compared to a lot of other countries. I mean, it's outstanding the number of fistulas. So that's number one. And then the other thing we had thought about looking at, or I mean, I think I've seen some of the raw data come through. There's a center, there was one center where they had, I don't know, I think it was like almost half the patients had catheters and only half had fistulas, if I remember right. And there, of course, you would never name what that center is, but you would just share with them the idea that the hope would be is they would decrease their number of catheters. In other words, if you share the data of what the norm is or the average is within Nepal, hopefully they would work hard to decrease the number of catheters and increase the number of fistulas. But the first thing, like I say, is to compliment all the doctors, nephrologists, surgeons, and so on in Nepal and say, what a great job of having very few catheters compared to other countries.
Yeah.
I did not expect that to be the case.
Yeah, we are also really, really like amazed to see this data. Like this is one of the biggest, like a large center, multi-center data from multiple centers. Even though it's only 20%, still we hope the remaining data will be similar. So we are. So let's see. Any comments by Dr. Sanjay?
I'm also experiencing that in Dhulikhel Hospital since past 6 months. The insertion of the tunnel catheter, rate of insertion of the tunnel catheter is also decreased. I also experienced that in Dhulikhel Hospital too. So more number of fistulas, more number of graft, but very less for the tunnel catheter insertion.
what I think is like the damage that is being done is because of period of time they put catheter. Like sometimes they are there for 2 months, 3 months also. So in our study, we have not included. We're not able to include that. How long are we keeping the catheters, temporary catheters?
So Dr. Navin,
I think all this.
in our next phase,
All,
we should aim for all those data also.
yeah, next step we should do that, because I think all the damage that all the cases that come to you, Dr. Robin, they come because they have put temporary catheters for too long. I've seen patients who have put temporary catheter for like 3 or 4 months.
And same with the tunnel catheter, like there are patients with tunnel catheter for 2 years, 1.5 years.
Well, I don't know. I have to figure out like where the person who told me, but they keep permanent catheter in Japan for too long, years, not just 3 years, but sometimes even longer, and they are happy. They were happy with that. So permanent catheters is much better than temporary catheters. I don't know what the practice is in United States, but they were even advocating for permanent catheter in patients in ICU who are having EKI.
Well, in the US and in Germany too, because Florian and I have talked about that, a temporary catheter would only be in for days, at most a week. I mean, they never leave the hospital with a temporary catheter. It just doesn't happen.
So even in patients who are doing the dialysis in ICU for acute kidney injury, they have started putting a permanent catheter in those also, bedside. So
They might have a temporary for a couple days, but they would never leave the hospital with a temporary catheter.
okay.
So any comments? I'd like to request Swechha for some comments. She has recently started her internship and into clinical. She is now in gynecology. So any comments from Swechha?
Thank you, everyone. The meeting was really insightful. And thank you, Sonia Di, for all your efforts. And we hope to see you soon. Thank you, Nobin sir. Thank you, Dr. Corey. Thank you, Dr. Dean. I have nothing to say. Thank you for making me a part of it.
So just going back to surveys, it would be good if we had more centers, but it's not uncommon for studies that are done with surveys that, you know, a good response rate is like 40%. I mean, by survey studies. Now, what would we want? Well, you'd want 50, 60, 70, 80, whatever. You'd like all of them, but most survey studies, 40% is considered good.
Now it's about 35%, but this is ongoing. So we'll be collecting the data from many centers. And although Sonia is leaving to US this Saturday, I think she will be working from US also.
Oh my.
Yeah.
So Sonia, you leave in 6 days?
Yeah.
Yes, Dr. Dean.
So Dean, you should be saying coming, not leaving.
That's
Right,
right.
exactly.
She's
She's
coming
coming
there.
to you, Dean. She's coming to you.
Oh, yeah.
Yeah.
Still
I told you.
2,000 miles away, but you know, what's a few miles between us?
I told you, Dean, that everybody wants to go to US since Columbus discovered the US.
Yeah, it's the wild turkeys. All right, so very good. Well, I'll be, like I say, I think this is interesting data. And one reason to have collected is how do you affect change? You know, and the thing I think we want to try and do over time is decrease the number of temporary catheters and number of all catheters, but compared to other countries, you're already at a low percent. I mean, 10% catheters is low. Florian, what do you think?
Yeah, it is. It's definitely it's. But as I said, it amazed me a little bit. So I wonder if really all of them are mentioned, because I mean, one other thing is, Dean, you and I talked about that too. We've never seen so many central stenosis as in the US, which we actually refer to the stiffness of the temporary catheters. So there's a maybe lack of information. I don't know. It doesn't really fit together. So if there were only so few catheters, then why do we have those kind of sometimes overwhelming problems? Because we don't see those central stenosis as often as you in Nepal, and all the cases we're talking about are from Nepal and not from here. So we have one patient among all those patients who had a central stenosis. We tried to dilate, and then eventually we gave this graft, his axis. We gave it up and created a new one in the leg, in the inguinal region. So as a bailout, but otherwise we barely see that problem, or not in the same frequency. So I think it's we need more data, but it's a very good idea, definitely, to collect them. And I think the aim behind it, or the idea behind it, is very good. So just to get more knowledge about it. So I appreciate what you're doing, and thanks for collecting the data, and thanks for doing this first giving this first talks on. Yeah, very good. Thank you, Navin, too.
See, I see central vein occlusion. Every time I have clinic, I see at least 2 patients with central vein occlusion. And I it's because those that don't have central vein occlusion don't come to the medical center. So
it's a bias, you think? Yeah.
When you and I are in Dulikel, I mean, that's when the patients show up. I mean, Dr. Prem reached out to me just this week and said, "When are you coming?" Well, I know what's coming. I mean, he's probably got another patient with central vein occlusion,
Yeah.
So I don't know, Dr. Nabin, would you think that's the case? I mean, Florian and I see them because the easy ones we're not going to see when we're there, right?
Yeah, maybe that's the reason. And I think we have a lot of central vein stenosis, and culprit is use of temporary catheter for too long time.
I think it's even, my guess is it's worse with temporary catheters, but it's also bad with tunneled catheters. But I don't see it, and I don't see it that often with pacemaker wires. Occasionally, but not that often.
Well, that's a difference, and I'd say it's, I mean, just in caliber,
Caliber, different material.
Yeah.
Yeah, everything.
So, Dr. We want to hear from Francisca also. Francie.
I'm happy to join. I'm happy to be here. It was very interesting, and I'm glad to join more often. Yes.
Yes.
So are you coming in March?
I don't know.
Maybe we haven't talked about that yet. We have to see if it works out.
Yeah.
But it would, we're talking of it, actually. Yeah.
So thank you, everyone. So Dr. Dean, can we wrap up today?
Yeah, we can wrap up. You want me to say something? Is that what you were asking me? I think we're done for today. That's about it.
Last, I would like to quickly introduce Dr. Manish and Dr. Manoj. They both are very new medical officers in our team. So Dr. Manish and Dr. Manoj. Okay. So they will be with us when you visit us in October. And Dr. Avinash will be in emergency. So thank you everyone for great presentation, great discussion, and all the insightful talks. So we'll meet in 1 month.
Okay.
Thank you, Dr. Robin, for invitation. And Florian, we would like to know the outcome of the case we presented. That's very interesting case, and
Yeah.
still I'm thinking what's happening on that.
Yes.
So
We
would like to
too.
hear
We
about
too.
that.
We tell you. We tell you. Okay.
Yeah, thank you.
Thank you, and have
Well
safe,
then,
Sonia.
have a
Good
good
night.
day. Yeah, Sonia, all the best for you. Take care.
Yes, Sonia,
Thank
all
you,
the
Dr.
best.
Florian.
Sonia, good night.
Thank you, Dr. Dean. Thank you, Dr. Nobby. Thank you, everyone.
Bye-bye.
Bye bye. Good night.
Bye bye.
Bye-bye.